Welcome. This is the Bladder Matters, what to do with the bladder that just misbehaves. I'm Dr. Robert Moldwin. I'm professor of urology at the Zucker School of Medicine at Hofstra Northwell, and I'm director of the Pelvic Pain Treatment Center at the Smith Institute for Urology.
And I'm Dr. Christina Kwon. I'm the director of Concord Women's Health Gynecology. I'm a practicing gynecologist and urogynecologist at Concord Medical Group in Manhattan, New York. So today, Dr. Moldwin and I are going to talk about overactive bladder and interstitial cystitis. These are two very common conditions which have tremendous impact on the quality of life of many women. The symptoms of both of these can range from simple bother to having severe disruptions in the basic functions of life. And many women are very reluctant to talk about these issues with either their doctors or even family members, simply out of embarrassment or a false belief that these are normal parts of aging. So Dr. Moldwin and I are here to talk about these conditions and hopefully provide some insight into them.
Great. So why don't we start off with the overactive bladder? Because this is something, I mean, everybody seems to be exposed to this. You can't really turn on your TV set in the morning and not hear an overactive bladder commercial. So Dr. Kwon, what makes this, why is there such a clamor to look into this? Why is there such a clamor to develop treatments for it? What's your take on this whole thing?
Yeah, this is such a common condition, and it is something that affects the lives of so many people. And it is something that the increased awareness of it has made it much more commonplace to be able to talk about. So broadly defined, overactive bladder is the sudden urge to urinate that can be difficult to control. And sometimes there is an involuntary loss of urine that accompanies this sudden urge and of urgency. And this is termed urge incontinence when this occurs.
So this, I mean, when urge incontinence occurs, this is not a very, is that something that typically brings a woman to the office to see you? Do they talk about this just routinely in your practice, or is it something that you have to sort of pull out during a conversation?
Sometimes people will make appointments specifically about this issue, but I'm always surprised at how much I have to actually draw this information out and ask specifically about, are they having problems with leaking before they make it to the toilet? And it just goes to show you how much of a stigma there is about talking about the situation. And then once they're asked, they're almost relieved to be able to describe the conditions that they're living through. And they often think that there's nothing that really can be done, or they think, I don't want to take medications for this, I guess I have to live with it. And that's not the case. There are many things that one can start to do that really will improve the quality of their life about this.
Do you think like a lot of people come to your office and they have these types of problems and they just are fearful with the kind of, diagnostic workup? I mean, am I going to have all sorts of invasive testing? Is that a concern that you see a lot of people have?
Yeah, I think that might be part of why people are reluctant to even bring it up. They are worried that they're going to have some kind of something that's painful, some test that's done that really is uncomfortable. And that's not really the case. Some simple tests that need to be done are just to rule out urinary tract infection first. So a simple culture, peeing into a cup. That is probably the one most important diagnostic test that has to be done to just rule out that very treatable condition that can certainly alleviate some of the symptoms that they have been having. Once a urinary tract infection has been ruled out, then really the history taking is probably the most important part of the evaluation of when someone's having these symptoms. And it's really figuring out what are the common patterns of triggering these symptoms that are occurring. And once we can sort of figure out what those patterns are, then we can start to put together a plan in terms of how one manages that sensation of urgency when they have it.
So basically the diagnosis is really pretty much straightforward. It's having the right symptoms. You're making sure with the urinalysis that there's no major other problems going on, I suppose. And then you sort of move along right into the treatment. Is that about correct?
That's right. That's right. It's important also to get a basic medical history. There's certain medical conditions which certainly can add to these symptoms, things like diabetes, history of stroke. So there are some common medical conditions which will play an impact in terms of how we manage these symptoms going forward. That said, they are still treated the same way in terms of determining what are the patterns and habits that are surrounding the symptoms, and then learning how to manage those things. I often call this practice of bladder practice or habit retraining, and much of this is figuring out when the urge-related symptoms will occur. So there are some common triggers for this for many women. So some common ones that come up over and over again are the key in the door. They are fine until they get to the door and they take out their key and then suddenly they just have to go to the bathroom. Another common one that happens is they're riding up the elevator to their apartment and they suddenly feel this urgency coming on to them. Another common one that happens in the house is that they are washing dishes in the sink and suddenly they have to stop and they feel urine or they have to run to the bathroom. So these are
That water coming on the hands, right?
yes, exactly. Yep. I think that has
So
something
what
to
do
do
we,
with the sound of the water plus even maybe the warmth of the water that is happening.
it's really interesting, isn't it? Because clearly there is some psychological component to this. It's not just the bladder over contracting. It's such a complex interaction between our upper portion of our nervous system and how it interacts. It interacts with the bladder function.
That's right. I mean, it's an important sensation to have. We want to be able to feel when the bladder distends and when the bladder needs to empty. However, those feelings can actually be difficult to differentiate from when the bladder physically needs to do these issues, and how we respond to those feelings of urgency are really what we can manage. We will feel urgency. Different situations will provoke this sensation of, oh, I'd like to go back to the bathroom. And it's really about managing how do I respond when I feel this urgency, because we can't necessarily stop that we will feel this sense.
So let's segue now into the treatments, because I'm sure everyone wants to hear I have it, you've been diagnosed, and now, is it just what these television commercials are telling us? Is it just just take a bunch of pills and everything's going to be a-okay? Or what's your take on that? Should we start off with pills?
I think medications play an important role, but they're not necessarily what everybody needs for this. So even if somebody starts medication, I think the basic tenet of needing to reset our patterns and how we respond to that urgency is still at the base of how people manage this. I think medications are a tool that can be helpful in implementing that bladder resetting. If somebody is having significant incontinence, urge-related incontinence, I think that's when the medications are much more useful to start right away. If someone is having uncontrolled leakage before they make it to the bathroom, it's going to be very difficult for them to say, I'm not there yet to the bladder, if they don't have some other tool to help them. So even with medications, the bladder pattern resetting is still at the heart of it. And I think that that's very important to emphasize. Other two, no, I'm sorry.
Well, a question I had was, do you find that a lot of your patients just stop drinking? If my bladder is going crazy and I'm going to social events and have a social event to go to, I'm just going to stop drinking. I don't want that bladder to fill up. Do you see that as a problem with in terms of how patients respond to their symptoms?
I do find that many patients do fluid restrict before certain situations. There is an element of that is important also in terms of before, say, getting onto a subway or a commute home, that someone does not have a large amount of fluid or drink their Starbucks while they are taking that trip. And that will just help during those situations. But by and large, I think it's important for people to understand that even if they don't don't drink anything, their bladder will still be collecting the urine that their kidneys create. So stopping drinking isn't going to stop that they're going to have urgency. So it will help to a certain degree, but it will not completely eliminate their problem. Again, the issue becomes how to change how they respond to that sense of urgency.
Is there a role, or what's your take on the role for Kegel exercises? And actually, for those who are unaware of what Kegel exercises are, maybe you could explain that a bit.
Sure. So Kegel exercises is a common name for exercising the pelvic floor musculature. So the pelvic floor muscles are the sling of muscles that surround the pelvic structures. They're the platform upon which everything sits. And Kegel exercises are just like exercising any skeletal muscle in the body. So sometimes I'll use the analogy of doing bicep curls. So if someone did bicep curls, they may not notice a functional difference in their day-to-day because your pelvic floor muscles are always working for you. They're contracting reflexively when you cough or sneeze. They are what you sort of hold things with when you're trying to make it to the bathroom. But if one did bicep curls, you would notice, oh, my arm feels stronger. But functionally, it's when you would need that. If you picked up something heavy or tried to hold it for a long period of time, that's when you're going to really notice, oh, thank goodness I've been doing these bicep curls. So doing pelvic floor exercises is always helpful, just like exercising any skeletal muscle in the body would be to increase the resting tone of those areas. It's also helpful in terms of recruitment. It's quicker to recruit those muscles when you need them. They also have a little bit more ability to hold when they have that proper tone. That said, there's a limit to what those muscles can do. So they will, again, not stop that sense of urgency that occurs, but doing the pelvic floor exercises can give you a little bit more confidence in terms of when I do contract and I'm trying to hold back, it will be helpful to give you that little bit extra time to get to the bathroom.
That's great. And let's say, now you had mentioned these, patients do come in with rather severe symptoms at times, and you sort of know, as a clinician, Kegels and changing your fluid management and so forth, that just is probably not going to do the trick. You're probably going to have to intervene with other more aggressive therapies. So maybe you could say a few words about what types of medications you might
Sure.
prescribe,
Yeah.
and then
So
other higher level therapies that are available.
So the two broad categories of medications are what's called anticholinergic medications and the beta-3 agonist medications. They both types of these medications have very specific receptors on the bladder. Their main function, I like to think of as they help to keep the bladder more relaxed. They make the bladder a little less trigger happy, but again, it doesn't stop the sense of urgency that occurs. So these become a very useful tool in terms of giving someone more time to get to the bathroom, but it does not change if somebody is, say, over drinking fluid through the course of the day, or it does not change that certain situations will continue to trigger that sense of urgency. But the use of this medication may be able to allow for more time to get to the bathroom in order for those pattern resets to occur. I will talk a little bit more. If you do fail those medications, however, there are things that can be done. Concomitantly, one might start to do pelvic floor muscle exercises so that they have more awareness and increased tone of using those, so that in combination increases the confidence that somebody has that they will be able to change these patterns and to get to the bathroom and not to respond with such heightened awareness of when someone has when that sense of urge comes on. They have more ability to believe that they're going to maybe make it there on time. Working with a pelvic floor therapist can be helpful in terms of increasing awareness of those areas if that's something that one wants to do in terms of improving that awareness to use those muscles in accordance to that pattern resetting. If there is still significant incontinence issues, there are some neural stimulators that can be implanted that do help with changing the sensation or the pathways of how the bladder senses the sense of fullness. And that's probably the best way to explain how those devices work. Those are definitely reserved for the patients who have failed the more conservative treatments, though, including medications, and they still are having significant quality of life issues.
And the role of Botox now, actually injecting the bladder surface, what's been your experience with that?
Yeah, I actually find that to be a very helpful therapy. Again, it is something that you would want to reserve for trying. You still would like to try these other more conservative things first. However, going on to that treatment is actually a very good one. Botox, as we're pretty familiar with, tends to relax muscles. So it helps to keep the wrinkles a little bit away because it keeps those muscles from contracting. So it acts similarly to the bladder medications in that it allows the bladder to stay more relaxed. The bladder does not contract quite as easily. In this case, it is because the Botox material is injected into the muscle of the bladder, and that inhibits the contractility of the bladder itself.
So when you give a Botox injection, just like for wrinkles and all these kinds of things, what's a patient to expect apart from just, I mean, how long is it going to last for them? Is it, they have to come back for repeated injections? And what's been your experience with that?
Yeah. Typically, there is need to re-inject. The Botox basically will wear away after a period of time. And I usually tell patients that they should expect potentially about a 6-month time frame. For some patients, it's much longer. And I think in those particular types of cases, a person is able to start to successfully bladder reset and do the pattern resetting because they are allowed to be able to get to the bathroom more on time. So I think that when you have a more extended periods of time, sometimes years, where people do not need to have another injection, I think that there's a combination of those things going on. The therapy allows for the ability to change the patterns.
I see. So basically someone truly could be on, it's sort of like I can see sort of a pattern here going from very conservative therapies to more aggressive therapies, but often, at least from what I'm understanding, you're saying is that sometimes these therapies might be used in combination. Is that correct?
That's right. I think always at the heart of changing symptom response to these issues is really, and I go back and forth, I keep referencing it, but the bladder practice and pattern resetting. I think if someone thinks that these treatments are going to do it for them, I think that that's where someone might be very disappointed in what the treatment can offer them. So I think it's really understanding that there is an active role that the person has to do in terms of noticing when their symptoms are triggered, changing the situations or things that might be provoking those situations, and by changing, say, diet. So there's certain foods and beverages that also can cause increased sensitivity. So it may be figuring out noticing which foods and beverages are causing more of those symptoms. And that in conjunction with some of these other tools and treatments that we've talked about really is what's going to provide the long-term benefit in terms of a change, in terms of feeling like your bladder rules your life.
Right, got it.
I think one common thing that comes up when I talk to patients about their symptoms that patients don't often associate with their urinary symptoms is constipation. And I find that when there's many patients who have an element of chronic constipation issues and they feel a sense of pressure and fullness from their constipation, and they don't equate it with that pressure sensation often used to mean full bladder, and it sends them back to the bathroom, and they might eliminate some urine, but they still are not able to eliminate the stool, and that pressure continues to be there, and that increased discomfort is what starts to drive their symptoms, and sometimes that leads to a lot of pain issues in the pelvis. So I would imagine, Dr. Moldwin, that you must see this often in your patient population as well.
So yeah, that's a really common thing. It is really sort of where the overactive bladder probably intersects with patients who come in complaining of pelvic pain, because of course constipation itself can have a profound impact just on pelvic pain in general. But also, I think over the past probably 20 years or so, we've gained a really much better understanding how the bowel actually communicates with bladder behavior. So, for example, as you had mentioned, it may be associated with bladder underfunction. It may be associated with bladder overfunction. So you can get all sorts of different discomforts in terms of the bladder just on the basis of, how your bowels are doing. When we talk about something like interstitial cystitis, also called bladder pain syndrome, we see a huge number of patients who come in with this bladder oversensitivity with constipation, and it actually worsens their overall pelvic discomfort.
Is there some commonality to some of the preceding history events that you see in these patients?
Well, yeah, many patients. Well, maybe I should back up for the listeners. What interstitial cystitis or the bladder pain syndrome actually is. I mean, I think in its basic form, I would think of it as just bladder oversensitivity. Normally, as you just discussed, Dr. Kwon, it's patients with overactive bladder feel that they have that sudden urge, they need to get to the bathroom facilities. Our patients with interstitial cystitis need to get there, but it's because they have mounting pelvic discomfort or just frank pain. Some patients, there's a huge spectrum, and both in terms of severity of the symptoms, and even in terms of the age distribution. So we're talking about women who could be basically teenagers to older adults. The spectrum of severity can go from just a discomfort to literally feeling like your bladder is filled with shards of glass. So it can really take a toll, just like overactive bladder, on somebody's quality of life. And perhaps it's not as common as the overactive bladder. Recent studies show that probably about anywhere from 3 to 8 million women in the United States alone are afflicted, at least with the symptoms, not necessarily have a formal diagnosis made, but they do have symptoms consistent with this problem. The biggest difficulties we have with this condition is just that it's just underdiagnosed in most instances, probably because unlike like a urinary tract infection, you can find a positive culture and make the diagnosis and treat with antibiotics. Patients who come in with this particular problem, interstitial cystitis bladder pain syndrome, often they have symptoms, but you can look in their bladder, you don't see anything. There's nothing visible.
They've often had that history of having had repeated urine cultures that have been negative over and over again as well.
And it's so frustrating.
So does everyone who comes in for a workup need to have a cystoscopy, or what kind of workup would you do if say I came in and I have symptoms of pain, just like you described? What can I expect when I come to your office?
Well, that's a great question, because it may be different in different practices, but in general, it's sort of like what you were just discussing about the overactive bladder. I mean, the basic evaluation is your history taking and your physical examination. You're trying to rule out with that, other causes of pain. So for example, just like you had mentioned, constipation, that is something we'll typically ask, as I know you asked for overactive bladder. So we're looking for those types of what we call comorbid conditions, because sometimes you can be led off track. But if we really think that the patient truly has, their pain seems to be worsening when their bladder fills, they're going to the bathroom frequently because of this problem, they have a negative urinalysis, and they don't have any, urine infections don't seem to be a big issue, we can make that the diagnosis on what we say an empiric basis. So we just go ahead and start treating. Now, my personal preference is probably to also look in the bladder, at least on a subsequent visit. Mainly, this is to rule out what you see there on those pictures, some inflammation that might occur, and that might change the way we treat any given patient.
Okay, so if I've gotten the cystoscopy done and I'm part of the 85% or the majority of the patients that you will not find those issues in, so what can I expect next? What kind of treatments will you offer?
Well, just to sort of draw the similarities between interstitial cystitis and the overactive bladder, again, we start with really conservative management and we can grade up to very aggressive therapies. Basically, as you had mentioned also, your your discussion was perfect for my discussion
There you
because
go, good.
they sort of mirror each other a bit because every patient, I always say every patient has their own little fingerprint.
Yeah, yeah,
Not if someone comes in with just terribly severe symptoms, we're not going to start off with terribly conservative therapies. We know it's not in the patient's best interest
right.
to start off something that we know in our heart of hearts is just not going to work. So we might be a bit more aggressive with that patient. But in general, like I said, when we start off, we'll start off conservative. Very frequently, it's just changes in their diet. Often patients, that's why I asked you the question about the fluid intake and
Mhm.
the overactive bladder patients, because our patients tend to underdrink because they don't want to develop that pain. And
Yeah,
the problem with that is by underdrinking, their urine becomes more concentrated and they end up with more pain. So a lot of counseling is involved. There are various foods, various beverages that have a tendency in many patients to worsen symptoms. So we may focus in on that. And
I think we see patients sometimes on the opposite ends of the fluid spectrum. I often see patients who overdrink. Actually, they think that they have to drink 2 gallons of water on top of all their other intake that they do in the coffee and the teas, but they feel thirsty, so they want to drink. I definitely see probably more on that end of the spectrum, and then I also see those that really do need to drink more so that they improve the how sensitive their bladder feels from the urine that's produced. So mhm,
it's always a balance, there's no,
it is.
I hate to say it, but with fluid intake, there's just really no easy answer. Certainly, even in both patient populations. I mean, obviously you can underdrink to the point where it becomes unhealthy.
Right.
So we have to be careful about that. And of course, over drinking is not going to help either.
Right.
So.
Neither way is going to solve the situation for her in either of the scenarios there.
A rule of thumb that I often use is I think unless you're taking, various medications or vitamins that colorize your urine, something that I always find helpful with my patients is your urine is a color. Probably you have your own little dipstick there. If it's getting really dark and really starts to look like yellow paint, you are under drinking. Your urine usually should look like a light straw color. That's probably the general area that you want to keep it in for the average patient.
That's right. And I think having a little bit of a yellow coloring is very normal. I
Mhm.
think some people aim for clear, which is when we start to get into the over drinking patterns, which cause problems in its own for on either spectrum. Is there a use for pain medications in treating your patients?
Well, God, yeah, these are great questions. Yes, because pain is the central issue with our patients. And I think that most of the patients are ultimately placed on a medication that not only helps them with their bladder symptoms, but also helps them with their pain. So we try to deal with both the frequency, the urgency, trying to help them sleep a little bit better at night, because that's another terrible thing that can affect their quality of life. And we try to address the pain at the same time. So there are medications that interestingly can have an impact on all those events at the same time.
These are oral medications or medications that are applied other ways?
Well, yeah. So we start off with oral medications. Um, I'm not going to go into the technical points here, but there are medications that can relax the bladder, and also may have some even relevance to the patients with overactive bladders. There are medications that literally block pain transmission in the nervous system, particularly in the bladder, at even higher levels. We know that there are high histamine contents in the bladders of many interstitial cystitis patients. So groups of medications like certain antihistamines can have a really neat impact because they can help patients sleep and also at least theoretically reduce inflammatory events. We have medications that can coat the bladder for those patients who have truly sensitivity of the bladder wall itself. So there are lots of things that medications that will work for this condition. The other thing is that we used to think, and I'm probably oversimplifying interstitial cystitis and saying that it's an oversensitivity of the bladder. Again, I'm working with the NIH in a special project called MAP. It's MAPP, stands for the Multidisciplinary Approaches for the Study of Chronic Pelvic Pain. And in that study, we've been uncovering how many global problems, medical problems patients have. So for example, it may be associated with irritable bowel syndrome, fibromyalgia, pelvic chronic fatigue syndrome, and others. And so we realize that you can't often just treat the patient's bladder to get them feeling better. You often need to treat multiple organ systems, and that's why other specialists might be important in the patient's clinical care.
Yeah, so the history taking again comes into play here, finding out different conditions, other conditions that can have concomitant effects in terms of the symptoms they have. Do you ever use antidepressant medications for the use of these? Sometimes we use that for the overactive bladder. We use that to decrease. I sometimes will say we're not using it to treat depression, but we're using it to treat the bother that these symptoms that are causing.
Well, yes. So that's a perfect example is a medication called amitriptyline. It's actually a tricyclic antidepressant. We use it in very low doses. We're not psychiatrists, so we're not dispensing it for the use in depression. What we're mostly interested in is that it has many qualities that really help our patients. One of which, as I mentioned, it blocks pain transmission in the nervous system. It has, as you had mentioned, it's an anticholinergic agent, one of the medicines you mentioned earlier in our discussion, which relaxes the bladder. It helps patients sleep at night, which is wonderful. And when we have a patient who's getting up 6 or 7 times per night, and we get them down to 3 times per night because they're sleeping better, I mean, that's a major, I'd still not enjoy getting up 3 times per night, but when you were at 7,
Right,
3's still looking pretty good. So it does help.
Yeah.
Sometimes we'll go further and actually put medications directly into the bladder. We call that intravesical, vesical meaning bladder, intravesical therapy, so it can affect the bladder directly also.
You brought up nighttime, and we hadn't really talked about this before, but I think that's a common symptom that people will bring up. And a lot of times I'll mention that nighttime is sort of a separate issue. And I often will contrast if someone does not get up actually multiple times at nighttime, they get up maybe only once or twice, or they sleep through the night, but they're having significant urinary urgency and frequency symptoms during the day, then I sometimes will point out that difference there. And I say that your bladder's in you the same 24 hours a day. It's the same bladder day and night. It doesn't actually know what time it is. So when someone is getting up multiple times a night, it often is another reflection of sleep pattern or sleep quality issues. And many times the medications that we will use will help to change the bother that the bladder does, but it will not change the sleep pattern issues that have become deeply set in terms of the wakefulness. And it's often very similar times of night that people wake up. And so I also set that expectation that when people are starting these kinds of medications, unless I'm specifically giving them something that will help them with sleep, say amitriptyline, like you mentioned, that the sleep issue will often be a more challenging thing. We can really only help mainly with the symptoms during the daytime, and we can hope that their sleep quality improves. However, a lot of times that sleep pattern is deeply ingrained, and that is really what's a large component of what's waking them up at nighttime.
Yeah, that's a very good point. I mean, avoiding during the evening hours is a very complex issue. It's not always, as you said, it's not always just due to the overactive bladder. It's not always due to pain that's making them wake up. Many times it's we uncover conditions like sleep apnea.
That's right.
You say there are certain, and that's just one particular problem. There are some patients who, for example, they tend to collect water over the day. And then when the legs go up at night, of course, that water comes back into the fluid comes back from the tissues, goes into so
there's more filtering and there's more creation of urine.
Right. So there's so many factors, and that's why it's so important You know, I think we don't work with patients as bladders or
That's right.
and kidneys. We always have to look at the big picture. Are there other issues going on that may have some relevance with respect to the symptoms?
Yeah, and even things like having a partner that gets up multiple times. Sometimes
Oh,
that
God,
actually
yeah.
starts the pattern disruption right there, and that's not something that treatment to the patient will necessarily change per se.
Yeah.
Mhm.
Never mentioned.
So lots of things are really figuring out what are these patterns and what causes these symptoms for these patients, and then really trying to find an individual approach in terms of what's going to work for them. And that may mean educating them about what the bladder function is, having them understand what brings on these sensations, and then really learning how to manage when they feel the sensations and discomforts occur. I think you see patients who have a more significant impact in terms of a pain quality, which can make it a little bit more challenging in terms of that pattern resetting without some mitigation of that pain nature that they're feeling.
Right.
All right, if you, I think as we're running out of time here, I think if you had one take-home nugget of information that you'd like to share with those who've taken the time to view our talk, what would you want to impart to them?
I would have to say that at least as far as interstitial cystitis, bladder pain syndrome is concerned, that no patient is the same. There are certain similarities between everyone, but everyone can be likened to a fingerprint or a snowflake or what have you. Everyone has their uniqueness, and I think that is extremely important that they're treated as such. Very few patients. I don't think there's any real cookie cutter approach to this business. I wish it wasn't an art form, but it is. When we see these patients and we see them frequently, you just get better at treating them and establishing, like I say, an individual plan. And if I could say one other little pearl that I would really hope that you take advantage of is basically the website that I left with you, the www.ichelp.org. So I think you'll find we can discuss all we like over here on this video, but you'll get so much more out of reading yourself what's going on in the field.
Yeah, that website does have a wealth of information on it. I think one take-home message I'd like viewers to go home with is really that you really do play an active role in managing these symptoms, noticing when the symptoms occur, and then learning how to manage the symptoms with the use of either your doctor's advice or with noticing if there's different things that are exacerbating the symptoms. Really take an active role on yourself to participate in. So I think that's something I hope that people know that there are things to do and ways to get help, either by themselves or by coming and speaking with their doctor.